Health Insurance Authority was established under the National Health Insurance Act 2003 Act 650 to ensure equity in healthcare coverage, access by the poor to healthcare services, protection of the poor and vulnerable against financial risk, among many other functions. A new law, Act 852, replaced Act 650 in October 2012 to consolidate the National Health Insurance Scheme, remove administrative bottlenecks, introduce transparency, reduce opportunities for corruption and gaming of the system, and make for more effective governance of the schemes. Here's a conversation Mike League Mamavio Uswa-Boaje had with the CEO of the National Health Insurance Authority, Nathaniel Otu, on the implementation of reforms to improve the scheme.
Thanks a lot for making time. Let's talk about, since you've been CEO of the NHIS, it's been a little over a year. How has it been?
Well, there's a lot to do. In this environment, you have to innovate every day. Things, develop very quickly, and you have to be responsive. So we've been responsive all this while. In the process, we've done quite a lot of major things to make the scheme better into the future.
Such as?
Well, under my tenure, we started an NHIS review, which was approved by His Excellency the President. What we've done is to look at the entire scheme and look at what can be done better. How can we make it more sustainable? How can it be more friendly to our members? And also to make it what we call a knowledge-driven organization that makes its decisions based on evidence.
Okay, so how far with that?
We have so far done all the processes relating to the review. We are only left with the last bit of submitting the review report to His Excellency the President through the Minister for Health.
So I see you're enjoying this position.
Well, it's a call to serve, and a call to serve, much as it is humbling, also comes with a lot of interesting times. I have been through interesting times.
Let's talk about the number of people who are on the scheme as we speak. How many people do you have?
We have 11.3 million members as of the end of 2015. We do measure our membership at the end of the year because there are exits and entries, and that's the procedure that we use. But maybe I'll use this opportunity to shed light on our membership. Oftentimes you hear it said that the NHIS membership has dwindled. In fact, 11.3 million is the highest since the inception of the NHIS. And let me go backward to 2009 when we changed our methodology. Until 2009, membership of the NHIS was on a cumulative basis. So every time we added a member to the scheme, it grew up the number to a point where we reached a certain situation. We said, look, if we continue this way, we're going to get more members than the population because you keep adding every year, new people coming. So from 2009, we said, we are going to use a new method. The new method is active membership. It means how many people have a card that entitles them to go to a healthcare facility. As of the end of 2015, we had 11.3 million of such people.
I think I was reading somewhere that the target you had for 2016, even though the year has not ended, you've exceeded that target. Is that correct?
It's the target of issuance of new ID cards. As you know, the work entails, one, getting in new people, but secondly, retaining those that you have. In terms of issuing new ID cards, for 2016, we set out to issue 4.3 million cards. As of the end of August, we had issued in excess of 3 million. We expect that we're going to issue about 8 million. But let me just punctuate this with a little bit of caution. One of the reasons why we've seen such a high registration, in addition to the interest in the scheme, is sometimes how people keep and handle their cards. So you have somebody go in, take their card, loses it, they come back for a reprint. Those have also added to the numbers. But organically, we are going to exceed our target by about 50%.
What does it mean? It means that there are a lot more people on the scheme today.
Absolutely.
But is this number one that you're capable of handling?
Well, I'll put it this way. We can't put a cap on the number of members we should get because it is envisaged that we'll reach universal coverage, and that's our optimal aim. As far as we reach universal coverage, the need to put financing in to resolve the challenges that come will be known for us to be able to make the appropriate recommendations. But as it is right now, We have covered 41% of the population as of 2015, and our expectation this year to cover 42%.
How many of these people are actually paying premium?
By our analysis, only about 30% pay premiums, and it's for a given reason. The law that establishes the health insurance scheme gives exemptions to 7 categories of persons: children under the age of 18, pregnant women, persons that suffer disability of a certain kind. Then we have people with mental health issues. Then we have indigents, people who cannot afford to pay the premiums. Then we have SNIT contributors as well. When you put all these together, they constitute 70% of the membership that do not pay premiums.
In the past, there were talks about increments, given a reasonable figure so that the scheme can better take care of the people who depend on it. Is that conversation still relevant today?
No conversation can ever be out, because in financing healthcare, all options are available for us to look at. Citizen contribution is something that has happened right from inception of healthcare delivery in the country. And if you read our healthcare history or health financing history, you see that the issue of how much the population should pay has been an issue right from the 1930s until now. It still continues to be an issue. Premiums that are paid within the NHIS account for just slightly less than 5% of all our income. The rest of the income comes from taxes and from SNIT contributions that are transferred to us. Those constitute about 95% of all the monies that we receive. So if you're going to make any big difference, the places where you get the most revenues are the places that you have to look at. But then at the same time, you do ask, there are issues of equity in this country and everywhere in healthcare delivery, issues of access to healthcare. And so you ask, who is consuming the services that are provided? Is it only the urban few? Is it spread to the countryside where everybody has access to an equal measure of services? I think for this country to be seen as an equitable country, we should offer services that are available to the population all around the country in an equal measure.
So let me ask you, who's consuming most?
Well, look at it this way. The cost of healthcare is complex because it takes somebody transport to get to a healthcare facility. And therefore, the more we bring health facilities closer to the people, the more we actually enhance their access to care. And so if you look at the ministry's policy and strategy now, is to bring a lot of CHIPS compounds close to the people to ensure that people get primary care as needed. That is something that the NHIS supports, because we believe that in so doing, the monies that we have will be spread evenly and many people will get access to services.
So can I conclude with that, that there are a lot of rural folks on the scheme?
Absolutely. I mean, the scheme is a big hit. Mostly in the rural areas. I mean, I have taken trips all around the country. One of the most interesting ones was when I went to a town called Wichau in the Upper West region, when I visited the facility, the polyclinic. I did a survey of all persons present, and about 98% of all persons present had an NHIS card.
Okay. So back to the issue of, would the premiums go up?
Premiums will naturally go up. We don't do it without proper planning. We do it in the context of a budget. As you know, last year we increased our premiums. We are still looking at increasing it. They can never be static, but they should also not be increased in a way that makes access to healthcare unaffordable for the population.
So is there a time by which time we would hear the announcement of an increment, or a certain percentage that's even out now?
You know, budgeting is a process. It has approval, levels, and I will submit, the institution will submit its proposals, and through those processes, including approval by Parliament, we are able to determine what is a rate that is acceptable to all.
In recent times, we've seen queues forming at some of your district centers. What's the reason?
I don't like to see queues in my district offices. I like to see people get services seamlessly. But seeing queues, it tells you two stories. It tells you the story that people are still very interested in the health insurance scheme. And when you go to the district offices and you see some of these queues, people express their frustrations. There are reasons why these happen. In most recent time, we like to be open and candid with our membership. I mentioned to you the fact that we had way exceeded our target for card issuance. Already by August, we had done 150% what we should be doing. This comes with logistical challenges. So you set out the year planning to issue 4.3 million. Suddenly you find yourself issuing 6-point-something million. Those items that you need to prosecute that will certainly have to be resourced. And so we got to a point where that was a little challenge, but we've gotten over that patch. We have adequate resources to register people throughout the year and even into early next year.
So maybe you don't have enough personnel on the ground. Could that be, there's a particular place in Jolu where there's always a queue?
Well, always a queue shows sometimes that maybe sometimes we have to decentralize some of our operations. And what we've done in our registration system, we have static registration centers as well as mobile registration centers. But when we've not served people in the static centers, it gets difficult to go out. And what we want to do is to clear people at the static centers within the next 2-3 weeks, and we'll be available to go into the communities to register people.
So how does it work? Do you register every year?
Yes, we do register every year. I'll come to you presently. And we're going to make an announcement that will bring a lot of respite to people. You would remember that before we started our new registration system, if somebody went to register, they had to bring a photo, a picture. They had to take a photo and bring it with them. That photo costs, in those days, about 10-20 CD. So the registration process itself was expensive to people, even including those who couldn't afford it. We have since eliminated the need for photo taking, and now photo taking is part of our registration process. So that new system has actually brought respite to a lot of people. Now, going back to the specific question that you asked, we don't think that it will be necessary in the near future for people to come in every year. So we are creating something called the multi-year registration system, where a member can choose to be enrolled for 2 or 3 years, maximum 3 years, and they don't have to come through the corridors of our office anymore.
Would you be paying a fixed premium then?
No, it will be certainly a multiple, because you'll be getting access to services over that number of multiple years. But in regards to the processing fee for registration, that we're going to look at.
Let's talk about your big plan for 2017. How does it look like?
Well, I spoke about the reform agenda that's going on. We are hopeful that by the beginning of 2017, a good look would have been given to the report that will be submitted. We want to enter 2017 re-energizing the NHIS and making sure that it lives beyond us and is actually a legacy to posterity. Now, on another score, a lot of things matter to us. Innovation is something that we pride ourselves with in this institution. And I can point to 5, 6, 7 innovative things that we've done. In 2016, we have decided to eliminate all paper in our registration processes, to the extent that today, when you go to register, you don't fill a form. It might seem like something trivial, but it costs money. And those forms alone cost us something in the region of about 6 to 7 million a year, which we have now eliminated. The next thing we've done is starting with electronic payments, where right now when people pay their premiums, it goes straight into a bank account. You can follow up on receipts, prevents losses and leakages and so on. The third thing we're looking at is the NHIS has become, should I say, a go-to place for validation of membership. So today our card has become quite widely accepted, and banks and financial institutions look at our card. We want to put more security in it to ensure that our card remains a preferred card. Next, we have claims is our core business. In a year, we process about 30 million claims for OPD, outpatient visits. This is pretty tedious because to date, a lot of it is paper-based. Come next year, 2016, we are going to automate a lot of these processes to make life easier for a lot of our providers. So these are some of the things we are looking at doing.
But you still owe your service providers, don't you?
We will always owe them. What matters is the extent of how much we owe them. By the design of the NHIS, when a provider provides services, they have 1 month to submit their claims to us. We have 2 months to pay. So if we owe a service provider for 3 months, it's not an issue because it's part of the design of the scheme. It is when it goes over and above this threshold that the people raise concerns.
So how does it look today?
Well, we do have a little bit of time delays.
Which is like how many months?
Well, it's variable, but it could be anything between 4 and 5 for most of them.
And what's causing the delay?
The delay is varied. I won't mention the district or the region, but just about 2 months ago, I got a lot of inquiries about a particular region where there were delays in payments. So I caused an analysis to be done on the claim submission. Lo and behold, it turned out that a lot of the providers waited a year to submit their claims. Some waited 180 days. But a large majority of our providers submit on time.
But what kind of reasons would they give for delaying about a year?
Some of it is, I guess, the structures of administration that are available. So, for example, when you go to a CHIPS compound, which is a sub-district health facility, they don't have their own financial management. So they depend, say, on a district health directorate. And so submitting through those layers sometimes causes delays. We believe that when we've brought the new claims application, it will get these things.
But would you still go ahead and pay?
Sometimes we make an exception. We look at the situation. So this particular region that I'm talking about, when we saw that, we didn't want to stifle the operations of the facilities. So we took the decision to pay and vet and reconcile, which we've done already. We have to ensure that the systems that are available don't fail. Health service has to continue being provided. But again, it's not all on the provider side. We have our faults also. And the faults that we have is for the fact that the operation is massive. You can imagine paying 30 million claims in a year, a lot of it paper-based. Moving into an IT environment, in full, is going to facilitate the processing of claims. So sometimes we ourselves delay a bit with processing the claims. Finally, the one thing is how the funds flow and how quickly we are able to access and get the funds to pay. I would say that there's been a lot of improvement. But putting all these things together, they give rise sometimes to the delays.
So when you say that there's been a lot of improvement, what exactly do you mean?
Well, in times past, we got releases 4 or 5 months late. But today, we are almost up to the required time that we have to get our release.
What is the required time?
The required time is 1 month administratively, but practically is 2 months. And I'll tell you why. When taxes are collected, especially VAT, what happens is that there is reconciliation done. We have input and output VAT. So in the first month, the taxpayer pays the output VAT, and the VAT service does a reconciliation. So realistically, 2 months is the time within which funds releases can be done.
Do you have enough funds?
I thought you were going to ask yourself whether you have enough funds. Nobody can ever have enough funds. We would like to do a lot more.
You are taking care of a lot of people, so.
Well, and that's what we say. We have to depend on what we call priority setting, because the needs are many and the priorities are competing. And where we put money is to be determined by all of us. It's one of the reasons why we've done the review. Now, in healthcare, there are many, many dilemmas. And I remember in one of my courses, one of the issues that we confronted ourselves with was a small country that had very little resources, where somebody had to be treated and the cost of the treatment was 1 million cedis a year, and it was going to go on for life. So the dilemma is, do you put all the money there? Do you do immunization to reach a lot more people? There are constant dilemmas that we all face.
But you're very proud of numbers. So, as you pride yourself with the numbers, do you see that what you have can sustain the numbers?
Well, I like what you said about sustainability. It's one of the key things that we always confront, because you can't run a system that is going to be a burden on future generations. Besides, you can't live beyond your means. We have to live within our means. And the way you can live within your means is to prioritize. As you know, the NHIS benefits package covers 95% of disease conditions that are presented in the country. And if I tell you, a single case of breast cancer treatment can cost us anything from 15 to 20,000 cedis. So if you have a lot of these on your package, it has an implication. And going forward, we look, and I talked about equity. How do the resources that we have spread and cover everybody equitably?
If we go the way we are going right now, can we sustain?
There is no healthcare system that can pay everything. The British NHS, I refer to these because these are the examples we are learning from. The German system, the American system, they all have challenges. We will have challenges. It's nobody's doing. It's inherent in the system that we built to provide healthcare financing.
Okay, so if we go the way we are going, can we sustain?
Well, we have to stop along the way and re-strategize because, as you may see, the benefits package and the numbers drive the costs. But of course, efficiencies are also important. Remember that when you look at healthcare costs, generally, in terms of inflation, they outstrip average inflation. So it costs more to provide healthcare than to provide normal services and goods in the economy.
In the past, we heard about some health facilities cheating the scheme. Do you still have some people trying to be smarter?
There always will be. It's a human organization and enterprise. What is important is to stop this from happening. And so, as I told you, a lot of our focus is about, making this not happen. But where we find people cheating the scheme, we do take steps to deal with them. Sometimes there are prosecution, other times there are delisting of these facilities. Sometimes there's just name and shame. And they all have their good effects.
But I haven't heard that in a while. So does it mean that for now, nobody is trying to outsmart the scheme?
As far as we see it, we report to the appropriate quarters if we think it's criminal.
Any pending cases?
Yes, there are a couple with the police CID.
Okay, so I want us to also talk about the challenges. You've mentioned a few, but what would you say is your biggest challenge? Is there political interference, for instance? Do you have issues with personnel or funds?
Political interference. You need the politics to run the NHIS.
How?
Because you need political support to make it function well.
We are talking about administrative.
When I talk about political support, I'm not talking about partisan political support, because the politics of the country is rooted in institutions, okay? So we deal a lot with Parliament, and Parliament has been completely supportive of the NHIS from all shades. The executive, supports the NHIS because it makes funds available, and it supports policies and strategies to make the system more efficient, more responsive to the needs of our people. So if, for example, you hear about, an NHIS review, it is because there is political commitment to it.
But you're not afraid of, maybe afraid is not the word. The political season is on, it's very heated now. Do you think that, for instance, our politicians will begin to play politics or partisan politics with the scheme?
No, the NHIS is fair game. It's because healthcare is very emotive and emotional. But at the end of the day, utterances must be backed by facts. And so if you use a word such as the NHIS has collapsed, it is unfair.
Which we hear a lot these days.
But you are the same person who talked about seeing people queuing to register at the NHIS offices. These two things, are at cross purposes. They don't confirm.
So people are queuing doesn't mean that the scheme is.
Well, why would
it's collapsing?
Why would people want to come in and register for a scheme that is collapsing? As an institution, we have challenges. Let's name those challenges and resolve them. I think that's a better way of going about it.
So do you have challenges with personnel?
Not really, no. I think we have enough staff to deal with our operations.
All right. Anything new you want to share with us?
I would say that the NHIS is something that can be nurtured and fostered by everybody involved. And in financing healthcare, we have three important people, or three important entities. The first is the member. So our members have responsibilities. An easy responsibility that I'll talk about is how to keep your card, not from losing it, not from defacing it. The next thing is to know your rights and to insist on them. Now, when it comes to the healthcare provider, they also have their responsibilities to provide care in a humane way at a cost that is efficient, but also to show respect to our members, and also to ensure that they bill according to the rules that are there. Now, when it comes to us, we have a responsibility to give our members a good experience when they register, to also ensure the services that are promised are given to them, and at the end of the day, to be accountable to the people of this country. So at the National Health Insurance Authority, we always have a full view of what is happening around the country at our district offices. And when I come into the office daily, I have to look at how we've performed over the week. But as you can see here, we're looking at yesterday's performance. Yesterday, we registered 30,290 people throughout the country with an average revenue in premium payment of 9.96 pesos, and total revenues for the day is as much as you can see over there. This is the number of new members that we registered, renewals, and the revenues attributable to the renewals and the new membership. Over here, you see distribution by category. So the biggest category is the informal sector. You asked me those who are paying premiums. Those are the informal sector. That's 28%. It's almost 30% for yesterday. Then we have the regional distribution, and you can see that the biggest is in the Ashanti region, 18%, followed then by 13% for the Brong-Ahafo region, and so on and so forth. So that's just one of the portals and the dashboards that we have. Come next year, we'll be better in providing information with the whole system as it operates.
I've got a final question on the private scheme. Are they posing any kind of threat or challenge to the national one?
Not at all. Private health insurance is complementary to the national health insurance. The national health insurance is the base for everybody. You can join as of right by being a resident of this country. Being a member of a private health insurance scheme is by choice. It costs a lot more money than the national health insurance scheme. The minimum premium for a private health insurance scheme is 1,000 cedis. And the minimum premium for the NHIS is somewhere around 16 cedis. You can see.
So why are the private companies going for that instead?
Well, it's full cost recovery, whereas the NHIS is subsidized by taxpayers. So that's the difference. But then again, it is the buying power. If you are able to use your buying power, you can negotiate better with healthcare providers, as it were. Now, one feature that is in the NHIS that is not in the privates is what we call limits. If you have a private health insurance scheme, there are limits to services. So, for example, it can be said that you can go for eye care services up to 100 cedis a year. If you get to 100 cedis, you have exceeded. So you've gotten to your limit. Anything else, you pay. In the NHIS, there are no limits. Everything is actually provided for and paid by the taxpayer.
But the private one also takes me to certain facilities on my choice.
In the NHIS, the choice is even wider. You can go to any facility in the country.
Is it?
Yes.
There are places where you go and they tell you we don't accept the NHIS.
Absolutely, that is true, because we don't force healthcare providers to be on the NHIS. But currently, we have 4,000 plus healthcare providers on the NHIS. It tells you the extent and the reach of the NHIS.
Is there a plan to get every hospital hooked on it?
We would wish so, but it's a matter of contract. You can't force people to to engage with you. But I guess when we make the scheme more and more attractive, providers themselves will join. I would say that every major facility in the country, government, is part of the NHIS. And for the privates also, a significant number of them are on the NHIS. And let me say that the NHIS provides a lot of the income of most of these facilities.
Thank you for your time.
My pleasure. Good to talk to you.